Right. Maybe we'll give it another minute and then we can get started. Right.
Do you want me to mute myself? I'll mute me for.
All right. Well, thank you everyone for joining us this morning for MGH Grand Rounds. We're really excited to have a really special guest, Dr. Amy Brodtmann, from all the way across the world joining us. She established the Eastern Cognitive Disorders Clinic following her return from her postdoctoral experience with Professor Marcel Mesulam at the Center for Cognitive Neurology and Alzheimer's Disease at Northwestern University in Chicago. Her exposure to atypical dementia syndromes and the diagnostic difficulties they pose inspired her to establish a Melbourne service at Box Hill Hospital, equal first in Australia, as at that time Professor John Hodges was establishing the Frontier Group in Sydney. ECDC is a specialist clinical center for diagnosing and managing atypical dementias, which has developed into an Australian referral service for frontotemporal dementia. On returning, she established Melbourne's first FTD support group in 2009 via close links with carers. The Australian FTD Association arose from these career links. It has operated as a charitable body since 2012, allowing a successful bid for the international conference for FTD in Sydney in November of 2018. AFTDA has now amalgamated with Dementia Australia while she maintains her medical advisory role in addition to her honorary medical advisor role for Dementia Australia. The ECDC Clinical Trials Unit is considered an exemplar for dementia trials nationally and internationally. She's been involved in over 40 Alzheimer's disease pharmaceutical-funded and investigator-led studies and has run or participated in 9 investigator-led FTD studies. She has experience with industry studies in FTD, as they were one of only 3 centers in Australia to join the TAU-RX OLEX study. Despite this being a challenging study, her group was internationally among the top 5 recruiting sites. They have excellent retention rates in all their studies, likely due to their close relationship with carers. They're also one of the world's leading recruiters for AD studies. They were one of the highest recruiters internationally for the Biogen Engage study for aducanumab, and at one stage, second only to 2 large US sites. An extraordinary achievement given that Australia's entire population is less than a tenth of America's. Building on this expertise, she has now been able to translate this successful model to the Royal Melbourne Hospital, where she has established the Melbourne Health Cognitive Neurology Service and restructured the Melbourne Health Cognitive Disorders Clinical Trials Service. Across both healthcare networks, they now run more than a dozen industry and investigator studies. She was involved in trial protocol discussions with Elector, Roche, and Biogen. She is the national chair of the Biogen Scientific Advisory PICO Committee and the national leader of the Elector FTD study. She is named Australia's leading cognitive neurologist. So without further ado, I give you Dr. Brodtmann.
Thank you so much, Jonathan, and thank you very much for the invitation to speak today. I am honoured, and it's a delight to be able to join you quite late at night in Australia. You'll have to forgive my husky voice. I am recovering not from COVID this time, but from RSV, and so if I do cough and splutter a little, I'll just pause briefly and mute myself so you don't have to listen. So with that beautiful introduction, I'd have to say that today I'm actually going to be talking more about my clinically led research, which is on drivers and determinants of post-stroke cognition. I trained as a cognitive neurologist initially, following my stroke training. So I have worked as a stroke neurologist for more than 2 decades. So some acknowledgements before I continue. Just making sure my talk is working. I live and work in Australia, and all of this work was done on the lands of the Wurundjeri Woiwurrung people of the Kulin, Eastern Kulin Nation. And I acknowledge that many of you are attending and joining us on the lands of the Wampanoag Indian Nation. I acknowledge their elders, past, present, and emerging, and any First Nations elders who are viewing this presentation. Now, I wrote these learning objectives, which are available in the PDF that I've sent around. And essentially, I'm going to be speaking to you about what else is driving neurodegeneration in people with brain injury from vascular causes. So you've heard about the work that I'm doing in clinical trials in Alzheimer's and in NFTD. And in all of that, we accept these orthodoxies that there's a toxic brain protein that is driving neurodegeneration. Indeed, the concept's often conflated. But today I want to talk to you a little bit about this concept of vascular degeneration. And then we can see this in ischemic stroke. And I'm going to give you, I'm going to show you some data from a stroke model that we've been doing for years, following people with imaging. I'm going to review some of the imaging correlates of post-stroke brain imaging changes and probably give a little bit of a framework or some concepts of what might be driving post-stroke neurodegeneration and cognition. I've given all my disclosures to your good lawyers, and so apparently I'm good to go. So the overview for this talk is that I'm going to talk about vascular impacts on late life cognitive impairment and neurodegeneration. I'm going to give a little history lesson, I suppose, just to shift the framework. I'm very aware that in the audience, there are extremely experienced cognitive and stroke neurologists, and there are also more junior trainees. So I suppose this is going to be for junior trainees who have probably grown up with some orthodoxies. I'm going to maybe challenge them a little bit. It's what Australians do. I'm going to present some findings from Canvas, which is a study where we used imaging approaches to answer some questions regarding vascular neurodegeneration. And then right at the end, talk briefly about some neurone projects that we did that helped us understand some potential drivers of this degeneration. So it's a tripartite talk if you think that initially I'm talking about human evidence for neurodegeneration in association with stroke and vascular disease, then some human studies where we've looked at the association between cognitive and brain volume trajectories in vascular disease, and then maybe a little bit at the end about neurodegeneration. I'm going to try to leave a little earlier in terms of to allow some time for questions if you have any. So a little digression on neurodegeneration. I'm a big fan of Michel Foucault, who was a French historicist, historian in the 1980s, who wrote that context is everything, essentially. So we live now in this age of toxic proteins. These are the orthodoxies that we accept when we think about neurodegenerative diseases. Alzheimer wouldn't have known this when he wrote about Auguste Deter back in 1906. And Emil Kraepelin really named the disease in his honor. And since then, with the description of neurofibrillary tangles and amyloid beta, and then the genetic association of chromosome 21, it wasn't until the 90s, in fact, prior to that, neurodegeneration was thought to be largely vascular, that Hardy and Allsop and Higgins published their amyloid hypothesis. And that really postulated that amyloid beta comes first, and then all of the degeneration is driven from that deposition. If you like, the amyloid for neurodegenerative disease, the commonest being Alzheimer's, is the match that lights the tau, which drives the degeneration. So there's this concept of this pathological cascade, and this has really been propagated, and I use that term deliberately, because when Frost, Jackson, Diamond then talked about tau propagation with this prion-like transsynaptic spread, we've got this concept that these proteins are spreading throughout the brain. Tau, alpha-synuclein particularly, are the ones that seem to have this most prion-like spread. So there is this association, if you like, that neurodegeneration equals toxic brain proteins, and older definitions now essentially say that neurodegenerative disease are associated with pathologically altered proteins. I can't tell you how many times that, my fellows or even more senior colleagues will say to me, oh, hang on, you're saying, is this degenerative or non-degenerative? this person's got vascular dementia. Is that a degenerative brain disease? Well, yeah, but hopefully I'll give you some evidence for why I think that is the case. I think newer definitions don't have that definite equation, if you like, anymore. And in fact, this is a newer definition that I found when I was writing this talk that doesn't necessarily associate all neurodegeneration with toxic brain protein. Why am I banging on about this? Why do I care about this? Because we know that, in fact, vascular determinants are actually strong determinants of late life cognition. And as far as we know, there's no protein that's getting deposited with these vascular determinants. Many pivotal studies have shown that midlife vascular disease is one of the strongest risk factors for all-cause late-life dementia. If you see that famous diagram that's done by Jill Livingston, looking at reversible and irreversible causes or risk factors for late-life cognition, many of them are cardiovascular. It's true for all of them, and they've all been associated with cortical thinning and reduced brain volume as well. Indeed, we can see the cognitive effects that are strongly associated with the classical profile of vascular cognitive impairment and vascular dementia. Things like slowed speed of processing, executive impairments. We can see these in non-demented people who have hypertension. Actually, they can be seen in many other cardiovascular risk factors, even after an exposure for 5 years. So this is middle-aged people living their best lives who have hypertension. We can actually see a change in their brain processing. We also know that the effects of these risks can be mediated by exercise and diet. So that's the good news story. And certainly from studies like Progress and Sprint Mind, we've seen that treatment of some risk factors, hypertension, may reduce the risk of dementia. We do know from many epidemiological studies that healthy lifestyle is associated with lower dementia risk and slower cognitive decline. So the other indirect epidemiological evidence that we have is that dementia incidence in high-income countries, not all, but some high-income countries, is declining. And this has been seen in many studies throughout the world. In addition, we now understand that there may be some sex and dementia syndrome specific differences that are emerging. For example, we know that women who have cardiovascular risk factors are at greater risk of Alzheimer's, rather than men who have cardiovascular risk factors who are at greater risk of vascular dementia. So this might help to explain why more women than men actually have Alzheimer's in later life, but it's still being unpacked. And the big thing, I suppose, from my point of view, that really has driven some of my research is the religious order studies, or the nun study, which is one of my absolute famous studies. Most of you know this study. It's now become part of many of the data that presented are part of the Rush Memory and Aging study. So this is when they approached initially nuns to have medical and neuropsychological evaluations every year, and then brain donation after death. In fact, this talk that I gave in a different form last year, I actually called Nuns and Orthodoxies. And we know that from the nun study, and this was some of the earliest evidence that Snowden published back in '97, that contrary to what they expected, is that it was actually the presence of strokes and brain pathology that had the greatest effect on cognitive function. So those people who'd had strokes over their lifetime or were diagnosed with strokes when they had their pathological studies done had poorer cognitive function and a higher prevalence of dementia than those without. And in fact, amyloid status, which is this toxic brain protein, bore very little correlation with their cognitive profile during life. There was especially high prevalence of dementia in women with small vessel and microvascular disease. And this has now been borne out in all of the large longitudinal studies, the Baltimore Study of Aging, the Bioethnic Honolulu Asian Aging Study, as well as some studies in the UK, the Cognition, Cognitive Function and Aging Study, and obviously close to home for the team that I'm speaking to today, the Framingham Study. And it was Troncoso who commented that the severity of dementia correlated with the number of brain infarcts better than extent of amyloid, and in fact said perhaps this is initiator or stimulator or additive contributor to neurodegeneration. So if it is the additive contributor, or indeed if it actually is the driver of neurodegeneration, how is that happening? And how do we unpack that? Because there's no toxic brain protein in vascular neurodegeneration. So one of the problems of actually unpacking this is it's quite difficult because at least 10% of stroke inpatients have a history of dementia. So are they already on that dementia odyssey, if you like? Are they already on that trajectory? It's at least 10%. And I actually have to say at the moment, I think it's probably closer to 30% when I do stroke wards. 30% of these people have dementia at 3 to 5 years. And this was from Sarah Pendlebury's absolutely fantastic review that she did back in 2009. And the other thing from the NUN studies is that you don't die with one brain pathology. If you've lived your very best life, maybe you'll have none, but I think that's pretty uncommon. Most of us will have multiple or co-pathologies. And in fact, mixed neuropathology in the NUN study and in the Rush Memory and Aging study is ubiquitous. And in fact, the ones that seem to be contributing the most, the pathologies in the brain that seem to contribute the most, are those associated with small vessel and vascular disease. This was a study that was done by Boyle, again from the Chicago group, and they found that infarcts, CAA, athero, and arteriolosclerosis were very significantly contributing to the proportions of cognitive loss. So this got me thinking about the group of patients that I'm going to be presenting today. And obviously this is a loaded question. I'm asking, which of these died with dementia of these patients? And these are some pathological findings of patients that have been involved in the Canvas study, I'll talk about in a moment, who've actually gone on to donate their brains. And you can see that there's mixed neuropathology, which is what we'd expect. Obviously, these patients have all had strokes, multiple strokes for some of them. And some of them have got very little amyloid. Some of them have got a diagnosis of Braak stage 4 or, really high evidence. And in fact, our pathologist said this person's got Alzheimer's disease. Some of them have got microinfarcts and prior atherosclerosis and lots of infarcts as well. So if I ask, which of these people would you think has diagnosed had dementia before their death? Well, obviously I'm talking about vascular neurodegeneration. It's not the person with Alzheimer's in their brain. It's actually the person with lots of infarcts. And when we looked at the pathology of these people, and these are some slides that Katrina McLean and Fairley Hinton from the Victorian Brain Bank has kindly shared with me, these microinfarcts are really important. We're looking at tau and amyloid pathology as well. But one of the things that we don't often look at in brains is that it's really hard to look at white matter atrophy, and it's really hard to look at any evidence of neuroinflammation. And one of the things that's missing from these slides, and that is often not reported, is microglial activation. And we now know that neuroinflammation is hugely important, but it's not in this frame. Most brain banks, in fact, don't do stains for neuroinflammation unless people die with an infective cause. And most of the time, we're not looking at these inflammatory changes. Now, some certainly are now. And as this is really a hot topic in dementia at the moment, there's some fantastic studies that are being done looking at inflammation. But remember also that the neuroinflammation, these people might have had a stroke, years beforehand. So do they still have ongoing neuroinflammation there? Could that possibly be driving the changes that we're seeing down the track? Possibly. I think the field in dementia is really changing. If we look at the agents that are available in phase 3 trials at the moment, and this is for Alzheimer's disease, which does have this positive toxic brain protein, that they're not just toxic proteins, that there's many targets that they're looking at, ApoE and lipids and lipoprotein receptors and inflammation. And in fact, most of the studies aren't just targeting amyloid and they're not just monoclonal antibodies, although obviously you've got 2 or 3 licensed monoclonal antibodies that you could use at the moment for Alzheimer's in the States. But they're actually targeting a lot of different targets. Again, this concept of co-pathologies, this concept that there's more to late life cognition than just a single pathology. So this is where Canvas comes in. And what I'm going to do with this study is that, so this is cognition and neocortical volume after stroke. I'm going to talk about how we perhaps can demonstrate vascular neurodegeneration. Perhaps we actually can see that these vascular changes are driving brain volume changes. We know that neurodegeneration, one of the signatures is actually brain atrophy. I know that seems obvious to say, but I think that there's often has been this difficulty in understanding if brain atrophy is accelerated in people who just have a stroke. And again, you'd think that that would be easy to do, but because of the conflation of, pre-existing cognitive dysfunction and all co-pathologies for stroke patients, it actually hadn't been done a lot over the last 20 years. And so we decided over 10 years ago to look at whether, very clearly, did stroke survivors have greater total brain volume loss? Very obvious question, very simple. We also wanted to see whether those who had cognitive impairment at 3 months after stroke, so allowing for native mechanisms of recovery, seeing if they were better, did they then go on to have greater brain volume loss over the next 3 years? That is, was the cognitive impairment coupled to some extent with the neurodegeneration? By definition, really, that idea that the neurodegeneration was causing the cognitive impairment, although causal studies, as everyone in this audience knows, are very difficult. So this brought up this concept of the study. We recruited from 3 different stroke units in Australia, in Melbourne, and we also recruited healthy controls. These were relatives of the stroke, the wider community, and we wanted to just look at adults because I'm an adult stroke and cognitive neurologist. We only looked at ischemic stroke, so we should have called this CANVAS rather than CANVAS. They had to have confirmed stroke. They had to be able to probably live for 3 years. So they couldn't have, a massive stroke coming in with a NIS of 24, etc. And they could have no history of dementia or any other neurodegenerative conditions. So we were trying to pull out that co-pathology as much as possible to sort of say, okay, you had to be cognitively normal. And we were very, very particular about this. We interviewed the patient, we interviewed their loved ones, their families, we were able to interview their primary care physician, we were able to interview the nurses who were looking after, to really say, no, this person does not have a history, that they're already on a cognitive trajectory that is going to lead to a dementia. More on that in a moment, because I think that you can only do that to some extent. We got lots of information about these people. They were closely phenotyped. We took blood tests. We also did MRI scans on a number of different occasions. And in fact, we recruited them within the first, say, 3 to 4 weeks, median time of 23 days. But the main recruitment time was at 3 months, because that's the comparison we were really interested in. 3 months and 3 years. We scanned them at 1 year, at 3 years, and again at 5 years if they were still alive and happy to be included. And our hypothesis was simple. We said, okay, controls are going to lose brain volume over this time, but what about our stroke patients? We think that they're going to start at a smaller brain volume because, as I just said before, all of those vascular risk factors are associated with reduction in brain volume and an increased risk of late life cognitive decline. So we thought they'd start with smaller brains and have greater decline. And those that had dementia or cognitive impairment would probably have more decline. We did fairly closely phenotyping in terms of our neuropsychological assessment. We divided them into 5 broad domains: memory, verbal and visual, visuospatial function, executive function, language, and attention and processing speed. And these tests were all done at each of those testing time points or study visits that I'd showed you before. So we wanted to ask a few questions. We wanted to say, when does the neurodegeneration occur, which I'll go through now, and then was that associated with cognition? So the neurodegeneration has occurred by the time that the patient hits the ward. So that concept that those vascular risk factors are reducing brain volume was manifest in our patients. In fact, we wrote up our baseline patients for a paper in neurology back in 2017, where we basically said brain volume's compromised at the time of stroke. So they already have some vascular impacts. And I'll show you that others have done this quite elegantly with some epidemiological studies to show that they've already probably got some cognitive impairments that are elicitable with our tests with no history of cognitive decline. So this is cortical thickness, total brain volume, hippocampal volume, white matter volume. And you can see at baseline that there was a difference in cortical thickness. This wasn't statistically significant, but what was significant is that our control patients had bigger hippocampi than our first ever stroke participants in the study, and much bigger hippocampi than our recurrent stroke. And indeed, when we looked at this, we didn't publish this in the paper, but these are all stroke patients, all control patients, the hippocampal volume. The participants who had recurrent stroke are the red dots. They all had hippocampi that was smaller again than the median that we'd expect for the stroke group, suggesting that yes, the vascular impacts were manifesting, but the stroke was almost causing a dose-dependent reduction in hippocampal volume again. And this again, I should emphasize, these are not necessarily, so our first ever strokes are exactly that, first ever clinical event. When we published this, Dave Brodtmann and Brodtmann wrote a lovely editorial, which really said that this was quite a departure of the thinking beforehand, in the sense that we were saying that these events or these risks actually manifest in a sotto voce way. They said a decades-long series of sotto voce whimpers. It was quite poetic for David and Babak. And it's really that only when we see these clinical strokes that we think, oh, yes, that's that patient's, got this disease. But there are these manifestations that are silently happening in the background. This shouldn't surprise us. This is a gorgeous study that was published a couple of years after we published our paper, also in neurology. This is from the ELSA study. And this is a study of almost 9,000 people, more than 9,000 people, who were in the community and were followed up with cognitive assessments and with some other medical assessments annually for 12 years, for a period of about 12 years. There were slightly more women than men, and they were pretty young when they started in the study. So around 63, meaning they were finishing in their mid-70s. In this study, they had about 470 incident strokes. So these people hadn't had strokes beforehand. They had an incident stroke in the midst of the study. Not surprising. What was fascinating is that those who had a stroke during the study showed decline in global cognition, memory, semantic fluency, and temporal orientation before they had the stroke. So these vascular risk factors were not only manifesting in the brain volume changes that I've just demonstrated, but in their cognition. Hard to detect and really only easy to detect with these large studies. And their global cognition declined over time, but you can see there was a stepwise decline, but then a decline over time. Subtle, not always easy to pick up, obviously hard to discern from their post-stroke cognitive deficits as well. So what we were really interested in as well was, okay, these people are, sorry to move this around, I hope it's not driving up the wall. We really wanted to say, well, these people have got these compromised brain volumes. Potentially they've got some cognitive problems that we can't really get at because they're subtle. If they're losing brain volume and losing cognition in that first, in that sort of early post-stroke period, is this affecting all of the brain? Is it affecting some parts of the brain? Are some parts more vulnerable? Is there a window that we could find where lots of brain is being lost, where we could intervene? So we looked at, over the first year, cortical thickness, hippocampal volume, thalamic and hemispheric brain volume to see whether one hemisphere was atrophying more than the other. And we looked at this in the Canvas study as well. And what we've found is that, so these are just some simple line graphs. At the top for all of these are our controls who did lose a little bit of brain volume, but not very much. This is hippocampal volume, thalamic, total brain and hemispheric volume. The dashed lines are the IPSI lesional volume changes. The dotted lines are the contralesional, which you can see up the top. And what we found is that the hippocampi and the thalami especially are losing a lot of their volume in those first 90 days. The poor thalami continue to decline at a much greater rate, IPSI lesionally. And I should note, none of these participants actually had hippocampal or thalamic strokes. So it's not like we're getting ex vacuo change. We're not getting atrophy related to the fact that half the thalamus has been infarcted. This is loss because of degeneration, Wallerian degeneration, secondary degeneration, dare I say vascular degeneration. What is interesting is that this also, whilst this is terrible for the poor thalami, what it means is that you can see those first 90 days is actually when most of the volume loss is occurring. Well, it's most rapid, I should say. The other thing that's important about this is that this is a time where we're often seeing these people. So this is a time where we actually have interactions with them. That first 90 days, they're still coming to stroke clinics sometimes, still having investigations. So we could intervene there, whether we're thinking about a behavioural or pharmacological intervention. I won't talk about that in today's talk. Jonathan, you'll have to invite me back another time and I can speak about what we can do in that time then. So we have this rapid volume loss. So when is the brain volume loss occurring? Well, it's occurring before the stroke. It's occurring really rapidly after the stroke. It's affecting some areas much more than others, potentially a therapeutic window. But what about white matter? A lot of the studies that we've done in the past where we look at the imaging signatures for brain volume loss in Alzheimer's, frontotemporal dementia, classically they've been cortical thinning patterns. What about patients who present with vascular risk factors? I mean, what about those white matter hyperintensities? What about all those changes that are happening in that so vulnerable white matter? So we looked at this at our patients at 3 months. Now, we had some beautiful diffusion imaging sequences that we did as part of this study, and we were able to do a fixal-based approach. The advantage of fixal-based approach over some more kind of conventional tractographic or even FAMD approaches is that it really allows you to overcome those crossing and kissing fibers, which is a bit of a controversy in the diffusion world. So Natalia Grover-Brumley looked at our patients at 3 months, and so these are the p-values here. So this is, you know, the more significant values are coloured, and this is orientation. The orientation I find quite helpful because you can really, on these sort of non-3D maps, it's hard to say, oh, this is SLF, or this is callosal, or this is splenial, etc. But you can see that there is massive white matter loss at 3 months after stroke, that we're getting white matter loss in all of the major tracts that we sampled, that there's a lot happening in the callosum, there's a lot happening in interhemispheric tracts as well. So this is stroke on one side of the brain, but we're getting bihemispheric changes, mainly on the right side in this cohort. And I just emphasize that most of the patients in our cohort, I think just over 60% actually had right hemispheric strokes. So what about at 3 years? What's happening at 3 years? So at 3 months, I've shown you that they're getting white matter loss and they're having rapid hippocampal and thalamic loss. And what happened at 3 years? Well, at 3 months, we had 126 people attend, and 80 of those and 41 so 121 had complete assessments, including usable, valuable MRIs. And 80 of them were cognitively normal, 41 were impaired. We had 93 attend at the 3-year mark. So that was about our expected 20% attrition rate. And what we did find, interestingly, and I think this is important for many of the studies, is that significantly more participants who were cognitively impaired at the 3-month mark had died or were not available to attend at their 3-year visit, suggesting that we're actually missing out on a lot of the patients who are probably most at risk of cognitive impairment. So cognitive impairment at that 3-month mark is probably a risk factor for doing poorly, and we've shown this in other studies. So what do we find we found what we expected to find, or what we hypothesized to find, I should say, because there was lots of unexpected findings in this study. Total brain volume in the healthy controls declined at a much greater rate. Total brain volume in our stroke patients declined at a much greater amount than our healthy controls. Both declined, but the strokes much more. And those people who were cognitively normal at the 3-month mark had less brain volume decline than those who were impaired, or vice versa. The people who were cognitively impaired had greater brain volume loss. And again, this seems like a really sort of obvious thing, but it hadn't been quite so concretely demonstrated prior to this study. So what then happens to their cortical thickness? Now, some people have looked at this in the past. We didn't see changes in cortical thickness much in that sort of acute, when we looked at the comparison in our controls versus strokes at that in the baseline study. Or really at that 3 months, we didn't see any really significant difference in cortical thickness. And the cortical thinning patterns in post-stroke and vascular cognitive impairment have not been clear. In fact, one of the problems is that stroke is really heterogeneous. Obviously, it could be anywhere in the brain. And we know that there can be regional thinning overlying subcortical infarcts. Marco During, among others, showed this in a lovely study back in 2012. And it can be associated with microinfarcts as well. And the other thing that I'm just going to briefly educate, you probably all know this, but I found this fascinating when we were writing up these papers, is that cortical thinning in healthy aging actually exhibits asymmetry. So it probably also contributes to the fact that if you've got it's very difficult to work out how much is just normal aging, how much is actually the stroke. So this is a lot of work that's being done by the Enigma laterality work, amongst others. We know that the decrease in cortical thickness that happens with normal aging is asymmetrical. It's more on the left than the right. And this largely affects the frontal and cingulate cortices. Sorry. Women have thicker cortices to start with, again, more on the right than the left. And this concept of retrogenesis is quite ascendant in the normal development and aging field. That is, as we develop, we tend to have our primary sensory motor areas will achieve mature cortical thickness first. And then those, if you think transmodal areas or those heteromodal areas of the brain, achieve their cortical thickness last in maturation. And they're the first to thin. So Rose said in a great study back in 2021, that there's accelerated thinning of the thicker homotopic hemisphere is actually a feature of aging. So that was really interesting for me as well, because it really added another layer of complexity on top of how we're going to examine this in our study. So what did we find? Well, our cortical thinning in our canvas controls exhibited just that. Most of the significant cortical thinning was in the left hemisphere. We had larger clusters, which were in the temporal and some of the frontal regions. So essentially, our canvas controls did what they were supposed to do, bless them. They actually thinned as has been described, more on the left than the right. Our stroke patients showed significant thinning at 3 years post-stroke. And you can see that when we looked at the thinning associated with the ipsilesional cortical thickness, that is, obviously our stroke patients had patients on either hemisphere. Most had right, not left. So you can see there's greater thinning in what you'd expect, pre and post-central areas, because that's where a lot of their strokes were. But they're also getting a lot of thinning in their posterior cingulate cortices. This is a classic area that shows thinning in Alzheimer's disease. This is the node for the default mode network, which I'm hoping most of you aren't in right now. I'm trying to keep salience network activated right now. You can see that there's also some thinning in the contralesional hemisphere. Again, you can see it's more on the left than the right because most of our patients had strokes on the right. And that's great. We're actually showing some cortical thinning patterns. But what about some of the other risk factors for stroke? We know that ApoE comes up again and again as a risk factor for cardiovascular disease, cerebrovascular disease, and for Alzheimer's disease. What about those people who are E4 carriers versus non-carriers? Is there any difference? Because we've actually seen in the past that that's a risk factor for cognitive decline. And indeed, when we separated out those who had E4 carriage versus those who did not, we see quite different thinning patterns in really interesting areas, in the sense that these are our, sorry, this is busy, and I'll just walk you through it. These are our E4 carriers versus non-carriers, so that's the divide. These are the pictures that I showed you before. This is all stroke. Ipsilesional cortical thickness shown in both. And you can see that whilst there is this kind of really quite significant PCC changes that we're seeing in our all stroke, we're seeing anterior cortical, in fact, we're seeing the whole cingulum really affected. All of the ACC is affected more. Now, this is interesting because the anterior cingular cortex is, if you like, more associated with the cognitive deficits that we think of when we think of vascular cognitive impairment. When we think of vascular dementia, slowed speed of processing, difficulty with attentional tasks, executive impairments. And I should just emphasize that the carriers versus the non-carriers didn't differ in age, sex, years of education, Charleston comorbidity, hypertension, et cetera, et cetera. And we've actually shown in the past that there were differences in their cortical thinning in this right precentral gyrus as well. So what about their white matter? We've shown that their white matter was quite atrophic at 3 months. Did that continue? Did that white matter change continue? And you bet it did. In fact, this is a study that we published again in Neurology this year. Yes, this year. This is again Natalia's beautiful work. And she's shown that those areas that I showed you before that were exhibiting atrophy continue to atrophy. So these are a comparison. This is 36 months minus 3 months. So using the 3 months as the baseline and taking away the atrophy that we're seeing. So not versus controls. This is actually, they're looking at atrophy within the individuals that had stroke over this time. We're continuing to exhibit massive fiber density, fiber cross-section, and fiber density and cross-section changes. So they're getting that loss too. So what about cognitive impairment and its links with these changes? So I'm just going to whiz through this to allow a couple of changes. So what did we find? We found actually that at the first year after stroke, the profiles were pretty stable. We didn't see much in the way of changes. When we then said, okay, well, if you know that, again, these people who are E4 carriers show cognitive impairment in other studies, what happens if we compare them to our non-carriers? We've actually demonstrated that they perform worse in verbal memory at 3 months after stroke. They've got smaller entorhinal cortical volumes. And at 1 year, they've got a decline in processing speed and executive function. They also are the ones that had the ACC cortical thinning. When we looked at this, trying to use some pretty tricksy ways, some structural equation modelling to look at frontoparietal microstructural degeneration, was it that white matter health was actually underlying the executive function after stroke? Beautiful work done by Michelle Velsman, who was a postdoc in my group some years ago. We found that actually the impairments that we were detecting at 1 year were more closely associated with white matter integrity. This is when we were using metrics like MD and FA than when we measured and looking at the stroke severity. And she also went back to see whether or not the structural covariance networks, so this is actually resting state networks, and whether they were associated with specific tests. So we pulled out all the tests that they were doing. She looked at the brain network that was associated with that test, such as dorsal attention, executive control, and she found that the structural covariance networks actually were strongly associated with post-stroke neurodegeneration at 1 year. This is work done with Michelle again and Helen Zhao in Singapore. So again, just to remind you, we already knew that those who were cognitively impaired had greater brain volume loss. So there's no doubt those impairments, we think, are actually co-varying, at least. I can't say it's causal with the brain volume loss. Just to emphasize, though, there were some differences in those who were impaired versus not impaired. They were slightly older, our cognitively impaired participants. They were slightly sicker in that sense they had slightly higher Charlson comorbidity scores, and the strongest risk factor for late life cognitive decline was also higher, hypertension in the ones who were impaired. And when we looked back at those cortical thinning patterns, we actually found a lot of that was being driven by those who were cognitively impaired when we tried to pull that out in an individual way with some pretty clever modelling. And this shouldn't surprise people. We know that this has been shown in other studies with pooled analysis. Recurrent stroke, older age associated with faster decline. This has been seen at 1 year and at about 3 or 4 years as well. But why is this happening? And I'd have to emphasize that some of our patients also had amyloid imaging, and we found no association with the cortical or, in fact, with the hippocampal brain volume loss of amyloid. And I can talk about that later. What's driving this then? So alongside these experiments, we were doing some bedside to bed, but in fact the bed of the mice, so the bed to the bench, set of mouse and rat experiments that were funded with fantastic collaborators who do magnificent brain preclinical research. Vanessa Brait, Kath Jackman, Charlotte Amine and Lockie doing the endothelin 1 rat models. So we had 2 models, a big stroke model and a little stroke model. They all had cognitive testing with cohorts with touchscreen technology. They had longitudinal MRI with a different cohort, and a set of animals were sacrificed at each time point. I won't go into huge details because this is work that was done in collaboration, and I don't feel that this is my work, but the work of my brilliant colleagues. So what we did is we thought, okay, let's look over a long time and see what happens to these animals. Let's image them, let's do cognitive testing, and let's do histology. So we did this on our mice and we did this on our rats. And indeed, what we found was that wild type mice showed progressive hemispheric atrophy following big strokes. The hippocampus in these mice becomes progressively atrophic as well, but it's only when it's directly affected by the infarct. But what we saw on histology is there was widespread and pervasive microglial activation out until the last time that we would sacrifice these animals, which was 1 year after the stroke. And this is when they really recovered. They were in fact indistinguishable in their motor development, or motor activity, I should say, performance, than the non-infarcted or sham animals. And Charlotte Amine found a similar finding in our endothelin 1 rat model. These rats had tiny strokes, and in fact they had strokes that really they'd recovered from within a couple of days. So these tiny small cortical strokes were associated with persistent thalamic and hippocampal microglial activation, again right out when we were had a set of animals that were sacrificed at different time points over the time, right out until 48 weeks. So a year after, they were still having microglial activation that appeared pathological. And Werder Saida had a paper that was published last year in Brain Communications and showed that there were widespread diffusion MRI changes that we saw in these animals over this time. And so, yes, this is secondary degeneration. Yes, it's Wallerian. But the secondary degeneration shouldn't be associated with this profound microglial activation. And it suggests that this is actually mediating this vascular neurodegeneration. And these long-term brain structural changes in adult rats were associated with some cognitive deficits as well. Hard to detect in these rats. They are super smart and will do anything for a strawberry milkshake drink. So it's not surprising. There's lots of people who've said that there's reasons why we were going to be getting a decline potentially, or microglial activation, because there's a huge cascade of inflammation that is evoked by stroke, by ischemic stroke. And I think that maybe it's this price of plasticity and opening up the networks and allowing us to actually recover in some people, maybe those who are E4 carriers, maybe those with extensive prior strokes, maybe those with vascular risk factors to decline. So I hope I've demonstrated that these vascular risk factors are associated with this accelerated brain aging. I hope I've demonstrated that these people are more cognitively impaired than controls. Even if they're stable, but we know that they're probably declining before the stroke as well as after. These people have persistent, pervasive white and grey matter atrophy years after infarction. And the hippocampal and thalamic atrophy is most apparent in the first 3 months, which is a window for intervention. That's when we should be doing something. The infarcts in the mice and rats were associated with enduring microglial activation, even out to 1 year after stroke. And the cognitive status and genetic factors also influence these cortical thinning patterns, making me think that the imaging signature of vascular cognitive impairment is more than just grey, but it's probably white matter degeneration as well. Thank you so much for listening. This is some of the Canvas team, Michelle, Natalia, Mohammed, who's done this brilliant work. And these are some of the other people involved in the vascular studies that we're doing. Thank you again.
Thanks so much for such an incredible talk. If anyone has any questions in the chat or out loud, I can read them out. We can give it a second.
No problem. I'll just I'll chat while we're getting some questions. I should just have emphasized that we did do, as I said, we had amyloid imaging in a subset of patients that were involved, because people always say, oh, how do we know that they didn't have amyloid? And we didn't do tau imaging though. We are doing some tau imaging on people now, because it could be that the tau is being potentiated, and there's some amazing work that shows that.
That's great. It looks like we do have a question from Steve Greenberg, who said, thanks for the intriguing talk. How would you weigh out the brain effects of the stroke itself versus the brain effects of the vascular disease underlying the stroke?
I think that this is, really hard, Steve. I think it's one of the things that we've, most struggled with, particularly when we looked at the baseline changes and all of the beautiful data that people have produced looking at these longitudinal changes and showing that inflection point. What I think is really interesting is that there's been some great pathological work that's been done recently where they've looked at people with hypertension, and they're showing that there's actually, pathological microglial activation in these people. So that's mainly affecting the white matter. And so if we're we're priming the brain with those vascular risk factors, and there's no doubt that they're probably having, microinfarction as well. They're getting some white matter ischemia as well. All of these changes, white matter hyperintensities on pathology, even though this is a really fraught area, do show some changes, do show some activation as well as the dysmyelination and the maybe ischemic changes in the white matter. So I think that we may be priming, and it could be this series of, as Dave and Babak said, this series of sotto voce whimpers, this series of small events that are maybe priming the brain. And then we have, a stroke, which is, apart from an abscess, is one of the most pro-inflammatory things that we can do to the human brain. And then I think that's why we're seeing this inflection. We're seeing this brain volume loss because everything is activated. Everything's opened up to recover. There's a, big up-regulation and, everything's disinhibited and excited. And I think that is driving it along the way.
Does anyone else have any questions? I think we can wrap up then. I just want to thank you so much for joining us so late at night over there. And this was a truly incredible talk, and the work you're doing over there is really incredible and really inspirational. So thank you so much for joining us this morning or this evening for Grand Rounds.
My pleasure. I hope you all have a great day, and I shall toddle off to bed. Thanks a lot, everyone. Enjoy the day.
Thank you.